Welcome back, everybody. Let's jump straight into today's explainer. We are delivering an absolute masterclass today on standardizing osteoarthritis biomarker research, specifically looking at defensible vitamin D testing methods, and we're presenting this as a clinical lecture straight from Assistant Professor Dr. Farhad Mustafa Musa Atrushi, MD. So if you've ever had an observational study completely rejected during peer review because of inconsistent laboratory reporting, well, you are definitely in the right place.
A massive shout out right off the bat. Thanks so much to Assistant Professor Dr. Farhad Mustafa Musa Atrushi, MD. The incredibly rigorous clinical foundation and the standard operating procedures he provided literally form the entire backbone of our analysis today. We really couldn't do this deep dive without his work.
Okay, here's our syllabus for the session. First, the vitamin D biomarker dilemma. Then, standardizing assay selection. Defining defensible cutoffs. Controlling for seasonality. And finally, the final clinical protocol. The ultimate goal here is to prescribe a protocol that is strictly Strobeam compliant so it can withstand even the harshest reviewer scrutiny.
Let's kick things off with Section 1, the vitamin D biomarker dilemma.
So why do so many of these observational osteoarthritis studies just hit a brick wall in peer review? Honestly, it usually boils down to inconsistent biomarker reporting. Our starting point to actually fix this is understanding exactly what we should be measuring in the first place. Based on the Endocrine Review's consensus statement, total serum 25-hydroxyvitamin D, which, just to clarify, is the sum of D3 and D2, is literally the only defensible, universally accepted status biomarker for our models. It's the only one that reflects a patient's true reserve.
Moving right along to Section 2, standardizing assay selection.
All right, we know what to measure, but how do we actually measure it accurately? This is huge. The assay platform you choose fundamentally dictates if your study holds water. For research purposes, liquid chromatography tandem mass spectrometry, or LC-MS-MS, is our absolute gold standard. It perfectly quantifies D2 and D3 separately before summing them. Now, if your lab doesn't have access to that, immunoassays are acceptable, but only, and I mean only, if they are strictly CDC certified for vitamin D standardization and you've done your local verification.
There is a really clear decision matrix we need to follow here. It's an excellent guide to what we prefer to use to defend our work, what we can accept if resources are tight, and what we absolutely have to avoid. Seriously, pay attention to those avoid parameters. Using a non-standardized ELISA without batch quality control or calibration, yeah, that is a massive red flag. If you try to publish that, reviewers will instantly downgrade your work to strictly exploratory rather than definitive.
To actually survive peer review, your chosen assay has to routinely hit some exact precision and bias targets. Specifically, the CDC Vitamin D Standardization Certification Program demands a mean bias of 5% or less compared to the reference method and an imprecision of less than 10% coefficient of variation. And here's the kicker. This must be assessed using blinded serum samples. That is the baseline bar for entry in modern biomarker research.
Section 3. Defining defensible cutoffs.
Okay, so you've got the right assay and you've generated reliable numbers. But how do we interpret those numbers without just inventing arbitrary clinical thresholds? Because, let's be real, current guidance simply does not establish osteoarthritis-specific outcome thresholds. There is no magic OA protective number you can point to. So we have to rely on really conservative analytical categories, like the ones from the National Academies of Sciences, Engineering, and Medicine. That means under 30 nanomoles per liter is risk of deficiency, 30 to under 50 is inadequate, and 50 and above is considered sufficient.
And while you're crunching this data, you must set an upper limit flag. Any levels coming in over 125 nanomoles per liter absolutely need to be flagged in your models. General nutritional guidance firmly associates this extreme high end with potential adverse effects, so you really want to exclude them in your sensitivity analyses just to make sure they aren't totally skewing your results.
Here is the absolute most crucial point of this section. Do not, under any circumstances, treat these cutoffs as osteoarthritis diagnostic categories. A fascinating 2026 paper in Diagnostics showed that serum 25-OHD didn't significantly correlate with cartilage degradation when looking at ultrasounds or MRIs. It's a general nutritional status variable. It's a contextual exposure. It is not a standalone causal diagnostic threshold for cartilage degradation. You've got to keep that distinction crystal clear in your manuscript.
Which brings us to Section 4, controlling for seasonality.
We have to confront a massive epidemiological design pitfall here. You could have the most perfect assay and the best cutoffs in the world and still completely ruin your data based purely on the timing of your participants' blood draws. We really need to ask ourselves, is seasonality just some minor nuisance variable we can safely sweep under the rug?
The answer is absolutely not. Decades of epidemiologic work prove that serum levels follow a distinct sinusoidal curve. They peak in late summer and they totally bottom out in late winter. This means a single, unadjusted, cross-sectional measurement could hopelessly bias your statistical models by completely misclassifying a patient's long-term exposure. To fix this, you either need to restrict your recruitment to a single 8 to 12-week season, or you have to balance and meticulously adjust your regression models for the month of collection.
And finally, Section 5, the final clinical protocol.
Let's pull the whole shebang together into a highly actionable procedure. Interestingly, pre-analytical stability for vitamin D is actually quite forgiving compared to a lot of other biomarkers, but enforcing strict handling is how you ensure your biobanking meets that STROBE-EMI compliance. The optimal steps are straightforward. Collect morning fasting serum, centrifuge it within 2 hours, split it into aliquots to completely avoid any repeated freeze-thaw cycles, and then store it long-term at -80 degrees Celsius. Standardized handling is how we kill avoidable variation.
But getting the physical sample is only half the battle. You have to thoroughly record the mandatory metadata. Osteoarthritis biomarker interpretation is incredibly sensitive to covariates. You absolutely need the exact collection date and month for that seasonal adjustment we just talked about, along with BMI, sex, supplement use, physical activity, and inflammatory comorbidities. Think about this. Large dataset analyses commonly show higher OA odds at higher vitamin D levels. Why? Reverse causation. Patients with joint pain actively start taking supplements. If you don't record that supplement use, your data is literally going to tell a backwards story.
What's really fascinating is how we can localize the science. Take a high sunlight setting, like Erbil, for instance. We've mapped out a definitive 8-step protocol that directly addresses the most common reviewer critiques for that specific environment. It requires standardized LC-MS/MS or CDC-certified immunoassays, uses continuous nanomole per liter modeling, utilizes those NASEM categories descriptively, adjusts for the season, and rigorously reports all sample handling metrics. It's brilliant because it completely avoids overclaiming disease-specific thresholds while adhering to the absolute best modern principles. So as we wrap up this explainer, I want to leave you with a rather provocative question to chew on before your next major submission. Are your laboratory biomarkers truly defensible? Are they backed by strict calibration, quality assurance criteria, and proper epidemiological adjustment? Or are they simply uncalibrated assumptions just waiting to be torn apart in peer review? Standardize your approach, protect your data, and let's actually advance the field together. Thank you so much for joining this masterclass.